Hi everyone, our subject today is hepatomegaly in pediatric. Hepatomegaly is a liver enlargement beyond the normal value for age. Mean normal value for liver span are 5.6 to 5.9 cm in a newborn, 6.5 cm at 2 years of age, 7.5 cm at 4 years of age, and 9 cm at 12 years of age. In general, a liver age more than 3.5 cm below the costal margin in a neonate and 2 cm in children is concerning for hepatomegaly. History. A colic stool and jaundice in a newborn are concerning for neonatal cholestasis, including biliary atresia. Pruritus may be manifestation of cholestasis in older children. Fever, malaise, anorexia, sore throat, and rash are common findings in infectious mononucleosis. Jaundice, fever, abdominal pain, anorexia, malaise, and vomiting can be features of both acute or chronic hepatitis. Fever, weight loss, chronic abdominal pain, arthritis, rash, and oral ulcer can be present in autoimmune disorder. Poor weight gain, loss of neurodevelopmental milestone, ataxia, tremors, and seizure disorder suggest metabolic disease. Past medical history should include exposure to blood products, immunization history, and recent respiratory and GI illness. Prenatal history should focus on maternal infections, placement of an umbilical catheter, and RH or ABO incompatibility or torch infection. Family history should focus on early infant death, autoimmune disorder, and hepatic and neurodegenerative disease. Social history should include foreign travel, sexual activity, illicit use of IV drugs, and presence of tattoos. Medication history should include all prescribed and over-the-counter medication, including vitamin and herbal supplement. In the cases of an ingestion, a list of all medication kept in the house should be obtained. Other inquiries include recent insect bite, animal exposures, or ingestion of shellfish. Prolonged hyperbilirubinemia after 2 weeks of age could suggest biliary atresia, cystic fibrosis, and alpha-1 antitrypsin deficiency. Use of total parenteral nutrition can lead to cholestasis, bile duct proliferation, fatty infiltration, and early cirrhosis. Other chronic illnesses: heart disease, liver enlargement from congestive heart failure, cystic fibrosis, related liver disease, diabetes mellitus, increased glycogen secretion, severe anemia, extramedullary hematopoiesis, inflammatory bowel disease, increased risk of primary sclerosing cholangitis, obesity, non-alcoholic fatty liver disease. Examination. Finding liver age. Children less than 2 years can be normal up to 3.5 cm below the right costal margin. However, if more than 2 cm, further workup or referral may be indicated. Children more than 2 years, normal up to 2 cm. Verify all suspected cases of hepatomegaly by checking liver span. Finding sign of chronic liver disease. Liver is usually firm and enlarged, can decrease in size in advanced disease. Splenomegaly, ascites, capotmidosis, spider angioma, esophageal varices, and hemorrhoid suggest portal hypertension. Also look for signs of occult bleeding or bruising due to vitamin K deficiency. Finding tender liver may indicate hepatitis or acutely congested liver secondary to right side heart failure or Budd-Chiari syndrome. Finding coarse facial features suggest mucopolysaccharides. Finding splenomegaly in the context of chronic liver disease imply portal hypertension, in the context of other signs of viral illness, suggest acute viral hepatitis. In the absence of these signs, suggest storage disease or malignancy. Finding Kaiser-Fleischer ring or cataract, suspected Wilson disease. Jaundice is clinically evident in infant when total bilirubin level are more than 5 mg per deciliter, and in older children when level are more than 2 mg per deciliter. How to approach to child with hepatomegaly after performing history and physical examination, laboratory test, complete blood count, retic count, bilirubin, total and direct, electrolyte, glucose, total protein, serum albumin, ALT, AST, GGT, alkaline phosphatase, PT, urine analysis, urine drug screen with or without abdominal ultrasound. Is there underlying systemic disorder present? If it is yes, differential diagnosis, cardiovascular disease, right side heart failure, inflammatory bowel disease, obesity, collagen vascular disease, hematologic disorder, leukemia, sickle cell disease, histiocytosis, cystic fibrosis, sarcoidosis, systemic infection, post-bone marrow transplantation. If there is no systemic disorder, is there recurrent vomiting, altered sensorium? If it is yes, consider serum glucose, ketone, lactate, pyruvate, amino acid, ammonia, uric acid, urine organic acid. Consider referral for further metabolic workup. Differential diagnosis, metabolic disorder, Reye syndrome, fulminant hepatic failure, and hypervitaminosis A. If there is no recurrent vomiting or altered sensorium, is there neurologic deterioration or loss of developmental milestone or hypotonia? If it is yes, refer for a specific test for paroxysmal disorder and storage disorder. Differential diagnosis, paroxysmal disorder like Zellweger syndrome, lysosomal storage disease, Niemann-Pick disease, Gaucher disease, GM1 gangliosidosis, mucopolysaccharide, Hunter-Hurler syndrome, Wilson disease, glycogen storage disease type 1 and 3. If there is no neurological or loss of developmental milestone or hypotonia, is there a non-specific symptom of fever, malaise, nausea, abdominal discomfort present? If it is yes, send patient for serology for hepatitis A to the E, Epstein-Barr virus, serum ceruloplasmin, alpha-1 antitrypsin level, antinuclear antibody. Differential diagnosis, acute hepatitis, chronic hepatitis B, C, or D, chronic drug-induced hepatitis, autoimmune hepatitis, Wilson disease, alpha-1 antitrypsin deficiency, post-transfusion chronic liver hepatitis. If there is no non-specific sign, it is isolated hepatomegaly with or without splenomegaly. Consider abdominal imaging, ultrasound, CT, referral for biopsy or additional test. Differential diagnosis, hepatic tumor, fatty liver, hepatic cyst, hepatic abscess, congenital hepatic fibrosis, choledochal cyst, Caroli disease, hepatic outflow obstruction, Budd-Chiari syndrome, cholesterol ester storage disease, Niemann-Pick type B, Gaucher disease, adult 4, tyrosinemia, total parenteral nutrition, downward displacement of normal liver like pulmonary hyperinflation, pneumothorax, retroperitoneal mass, subdiaphragmatic abscess, and renal loop. Peers and pitfall. Transient hepatomegaly can occur with systemic viral infection, but can also be indicative of intrinsic liver disease or a more serious generalized disorder. A liver age more than 3.5 cm below the right costal margin in the neonate and 2 cm in children is concerning for hepatomegaly. The presence of palpable liver does not always indicate hepatomegaly. Ultrasound is the screening modality of choice for evaluation of liver and biliary disease. Alert: referral to gastroenterologist or hepatologist if unexplained or persistent elevation of liver enzyme, decreased synthetic function or sign of portal hypertension. Indication for immediate hospitalization, persistent anorexia and vomiting, mental status changes, worsening jaundice, relapse of symptom after initial improvement, known exposure to a liver toxin, rising PT-INR ratio, rising ammonia level, bilirubin more than 20 mg per deciliter, AST more than 2000, development of new ascites, hypoglycemia, leukocytosis and thrombocytopenia, hematemesis. Thank you for your listening.